Yeah, thank you, Rosa, and welcome everyone to the panel on innovative CHC responses for COVID-19 outbreaks. My name is Dr. Sinnwell, as Rosa said, and I'm joined with Dr. Corwin, and we're really happy to be here on this panel today with the Family Health Clinica from Wisconsin. So just to give you a little layout for the presentation, Dr. Corwin and I will go first, and then we'll hear from Family Health Clinica from Wisconsin. And then because it's a panel, we're excited to leave lots of time for questions and discussion. So the title of our presentation is Preparedness and Response for COVID-19 Outbreaks in Midwest Latinx Migrant and Seasonal Farm Workers. We have no disclosures or conflicts of interest to declare. Briefly, we have three objectives. First is to identify the health and safety challenges specific to migrant and seasonal farm workers during the COVID-19 pandemic. Excuse me. Describe factors that played a role in the mitigation and response to the COVID-19 outbreak among migrant farm workers in rural Iowa. And finally, list examples of how the Proteus model of care can be adapted to serve migrant and seasonal farm workers. Just a little bit about Iowa and farm workers. In Iowa, the major agricultural products include corn, soybeans, hogs, and eggs. Our state hosts approximately 7,000 farm workers each year, and most of our migrant workers travel from Texas and Mexico to work in Iowa. We do have several patches of migrant farm workers from other Central America countries, such as Guatemala. Dr. Corwin and myself have worked extensively with Proteus over the last several years. And Proteus is a HRSA-funded 501(c) nonprofit. It's a federally qualified health center that has worked with migrant and seasonal farm workers for the past 41 years. They have a long history of providing multifaceted support for farm worker families that simultaneously address challenges with multiple social determinants of health. So things like transportation and interpretation and access to health care. In Iowa, we offer mobile primary health care services to approximately 1,500 migrant and seasonal farm workers and their families each year. And this is regardless of insurance or immigration status. In addition, Proteus does operate in a tri-state region, so Iowa, Nebraska, and Indiana, to provide thousands of farm workers with health and safety training, such as heat stress and pesticide training, as well as educational assistance and job training. We're also able to provide the workers with basic support, such as access to food and cash-based financial support. So kind of like everyone around the country, in Iowa, as the 2020 agricultural season began, there are an increasing number of reports in the media alerting the American public to the disproportionate effect the COVID-19 pandemic was having on the health and well-being of the migrant farm worker population across the US. And we all know that migrant and seasonal farm workers are a vulnerable population with unique health and safety challenges related to the entire spectrum of social and structural determinants of health. These challenges place them at a disproportionate risk and illness as the result of COVID-19 pandemic. Due to their migratory nature of their work, sheltering at home or social distancing are not options. Workers often live in poorly maintained and crowded congregate housing where access to optimal hygiene and resources is usually limited. At one of the farms where we go each summer, they bring in about 400 to 500 migrant workers on H-2A visas from Mexico. So they bring them up on buses. They house them in one large area. So you can imagine the difficulty if there's an exposure to COVID-19 or a positive test for isolation of those workers. It's not like you or I where we can go back home, we can take vacation, we have access to health insurance. It presents a lot of challenges. Also, fear of pay cuts and job loss and deportation make migrant workers reluctant to report symptoms. And this makes infection detection through screening and treatment a unique challenge. It's worth mentioning that racist narratives and stigma may further deter these essential workers from reporting symptoms when they feel unwell. So I'm gonna go ahead and talk about how Proteus kind of changed their model over this past season to adapt to these challenges. Proteus is a known and trusted partner in the agriculture community, both among the growers and the workers. In a typical year, after registration and education of the registered migrant farm workers, we provide periodic primary care visits via mobile clinic services throughout their time here in Iowa. We treat a lot of chronic conditions, and oftentimes the workers, we're their primary care provider. This is the only time throughout the year that they're receiving care. But early on in the pandemic, our providers and Proteus, we proactively pivoted our model of care delivery, and we adopted a telemedicine option. We really wanted to maximize social distancing and protect both the farm workers and our healthcare staff. So we conducted telephone visits in the evenings, followed up by in-person visits the next day when necessary. You can see myself and Dr. Corwin visiting a seasonal worker outside of his home. We saw him over the telephone for management of his chronic hypertension and other diseases. And then the next day, we drove around 2 hours to check up blood pressure and deliver medications. This summer, we also conducted bilingual virtual town hall meetings with the workers to provide education around COVID-19 testing, social distancing, and other important prevention measures. And this allowed for a lot of question-answer discussion time, which was very beneficial. The farm owners and managers whose workers we serve also began the 2020 season with knowledge gaps and a lot of confusion over the CDC guidelines. There was also financial challenges related to the implementation of these preventative strategies in the farm fields and within living quarters. So Proteus assumed leadership for this preparedness and response as well early on in the season, reaching out to the local public health departments and even the governor's office. And we really wanted to provide support throughout the season for these growers and their workers. So we also provide either in-person or virtual education, talking about how to best protect the health and safety of the workers during the pandemic. But we really focused on this last season was widespread testing of the workers upon arrival to Iowa and mass distribution. We provided throughout the season a lot of guidance and just really coordination of support. When a worker would test positive, oftentimes the employer wasn't sure what to do, what the next steps were. And so we were able to kind of guide them through this process and contact tracing. The workers who were in isolation, if they tested positive for COVID-19, we were able to provide regular clinical follow-up in their living quarters, and hospital referrals were made for symptomatic workers when necessary. In addition to this clinical follow-up, the workers received support like food and water and supplies, soap, hand sanitizer. If they were isolated in a hotel, for example, we were able to provide meals for them. So this is a fun slide. It shows pre versus post-COVID. You can see all the changes that have happened this past season. In the upper left-hand corner, this is in the cafeteria, the workers are making pan. And so you can see pre-COVID, there's no masks. Post-COVID, we're wearing masks and goggles. If you move over to the right-hand side, usually we would conduct our clinics in the cafeteria at this specific location. And you can see we moved clinic to outside in the open air. Down below on the left-hand corner, in this location, we would set up in a laundry room. And again, we move this outside just to take further precautions. And then you can see on the right lower-hand corner, some of Proteus health aides are providing education to farm workers during their orientation and the implementation of temperature check screenings. So I wanted to talk a little bit about our first outbreak in Iowa. It was a small one, and it was very early on. It was in the spring, and it was 2 weeks after arrival. One of the migrant workers received a telehealth evaluation for wrist pain. And during a routine screening about possible COVID-19 symptoms, the worker reported a cough but denied all other symptoms. So the following day, Proteus health aides traveled to the farm, and they performed a swab. And because of the inability for these workers to really practice consistent social distancing, Proteus arranged for the worker to isolate in a local hotel immediately after testing. And soon after receiving the notification of the positive result, Proteus recommended testing the remaining 65 workers. And this was done in sort of a drive-through testing site. You can see one of the healthcare aides, reaching up into the cab, taking the swab. So out of the 65 workers, 21 were Latinx. The employer was very receptive and enabled additional testing. And some of the information that I'm going to present next about this case, this data is important, just keep in mind as Dr. Corwin talks. But among the Latinx workers, a total of 9 workers tested positive for COVID-19, so a 41% positivity rate. Except for the first worker, all positive individuals are asymptomatic. There were no positive test results among the remaining non-Latinx workers. 21 or 95% of the positive Latinx workers were male, and 20 or 91% of the Latinx workers only spoke Spanish. All the Latinx workers originated from Texas prior to arrival in Iowa. And now I'll pass it on to Dr. Corwin. Thank you.
Thank you, Emily. I'm going to talk about the outbreak mitigation, but backing up a little bit, just mentioning that high asymptomatic rate of infection. At that point in the pandemic, we were just learning about how important that asymptomatic infection was going to be for propagation of the pandemic itself. So going back to outbreak mitigation, prior to test results, prior to when we got them, all the workers were isolated in single-person hotel rooms. After all the workers were tested, the negative workers were released to low-density housing and then released to work. Daily check-in calls by Proteus were conducted, and that was to bring meals and sanitation products because everything was such a rush. I mean, it was all a big surprise to these workers. No one expected to be shuttled off into isolation. All the workers that were positive and isolated, they eventually were released healthy back to work after the appropriate 10-day isolation period. And there were no other outbreaks on this particular farm for the rest of the season among the migrant workers or among the local workers. And during the course of this outbreak, all these steps seem really simple and simplistic to conceptualize, but they actually, these mitigation efforts really monopolized the time and energy of the small Proteus staff for 24/7 for 2 weeks, until everybody was released back to work in healthy, stable status. Next slide. So over the course of the summer, over the course of the season, Proteus tested themselves 2,500 farm workers. There were tests done in coordination with the Iowa Department of Public Health as well, but Proteus really did do most of the testing. And there were no deaths during the course of the summer. We did have hospitalizations, we had isolations, we had sick people, but fortunately over the course of the summer, we didn't have any deaths. And everybody who did actually test positive and even became ill eventually recovered by the end of the season, and really in relatively short fashion. Next slide. So now I'm going to talk about the bigger picture here a bit. So early during the pandemic, the New York Times revealed county-level data from the CDC, information obtained by filing a Freedom of Information Act with the CDC. And this data revealed glaring disparities as shown in this graph. This brings up the issue of gathering data related to hard-to-reach populations, such as migrant and seasonal farm workers. And just a note, as I was waiting to do this presentation, on my email, the MMWR just came out with a fast release about exactly county-level data and COVID infections. So a little behind the times. But anyway, this data did come out fairly early in the pandemic because the New York Times filed the suit. Data gaps, next slide. Data gaps make it very, very difficult to grasp what's happening in many underrepresented communities. The New York Times data represented 640,000 cases in 1,000 counties. The Times had asked for ethnicity and race data as well as the county of each person, and there were still lots of data gaps in this data as well about missing points of race and ethnicity. However, it was really alarming back then. We were already seeing that Black and Latinx populations had twice the death rate of white populations. And this is really was the first best data of this kind. Next slide. So there's tremendous complexity underlying these COVID outcomes, and for sure there are pre-existing conditions like hypertension, diabetes, older age, obesity, and some of these conditions really are more prevalent in one population versus another, no question. And of course there are some personal choices in the mix, no question. But this is not nearly the whole story. It would be too easy, and it would be a bit of a cop-out, frankly, to leave it there. The bigger picture really requires an honest and deep look at the systemic factors that are underlying these COVID outcomes. And this is really done by addressing the structural and social determinants of health, like Emily was talking about earlier. Next slide. Back then and now, we needed and we need specific state and national policies that address crowded housing, communal meals, large group transportation, poor sanitation, and probably perhaps still inadequate personal protective equipment. We need support for testing still for isolation we'll need support, still for quarantine we'll need support. And now we're going to need support and resources for adequate vaccine access. Some states across the country have not even developed guidelines for farm employers or farm workers. In Iowa, we have some guidelines, but we have no legislation, nothing to back it up. Next slide. There are a few bright lights, opportunities for optimism. Biden announced an executive order protecting worker health and safety, and days later, he announced the Community Health Center program for giving health clinics direct access to vaccination. And of course, the devil is in the details, and it's incumbent upon all of us to dig in deep and figure out really what is and what is not covered in these initiatives. However, it is a far cry from cutting farm worker wages in the middle of a pandemic like we saw in 2020. Next slide. So Proteus has an ongoing survey of attitudes and willingness of our workers to get vaccines. We now have over 100 responses, and this will be ongoing. Most say they'll get the vaccine. There's a pretty big chunk of people that are reluctant and uncertain, but not most. And many do have concerns, even the ones that are saying absolutely they want the vaccine. They're still articulating concerns. So having concerns and wanting the vaccine are definitely not mutually exclusive. Just last weekend, we collaborated with another clinic and oversaw the vaccination of 20 workers who had just arrived. And all workers wanted the vaccine. There was a lot of sort of nervous laughter and joking around as they took off their shirts and rolled up their sleeves, and we called one name after the other. But nonetheless, they really all wanted the vaccine, and the environment was really very upbeat. So we're only beginning to see vaccines on the horizon for these workers, and the rollout across the country is still very uncertain and, again, very disjointed. Next slide, please. So in summary, without state and federal coordination, this pandemic has resulted in tragedy for farm workers across the country. The migrant and seasonal farm worker experience during the pandemic is, a stark reminder of what we know has existed for many, 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 many years. Age-old time disparities that we have always existed. And it's imperative that we, as a nation, now reflect upon this experience and really address the social and structural forces that perpetuate these inequalities. The pandemic has made our national reality undeniably clear. Disparities make our entire nation vulnerable, as the health and economic well-being of our nation and our farm workers, our vulnerable farm workers, are forever intertwined. Next slide, please. So at this point, we would really like to thank Daniel Hoffman-Zinnel, Carolyn Johnson, and all of the staff at Proteus who really worked tirelessly on behalf of farm workers across Iowa. And a very, very special thanks to our farm workers, our migrant and seasonal farm workers who perform the essential work of feeding our nation year after year. And then that is it. So thank you very much for listening to our presentation. And now I will pass it off to La Clinica.
Wonderful. Thank you so much. So I will note with this first slide that our presentation does view a little bit more on the COVID risk mitigation project that La Clinica did this past summer. And just a little bit of it will be the primary care portion that we continued on this past summer. So with this, if I can have next slide.
Great. Thank you, Netzali and Drs. Corwin and Sinnwell. Really interesting to hear your experience south of our border as we work in the state of Wisconsin. So both the information around the work you're doing, but also challenging all of us there with some questions around policy and advocacy work to help continue with maximizing the well-being of our farm workers. We appreciate that. So just as a quick overview and introduction from our team, and we do appreciate the chance of being here today and sharing our experiences, and Netzali and I get to represent our whole team that actually has been out even today on a mobile mission doing some testing and vaccinating. So Family Health Clinica is a federally qualified community health center. We're in the center of the state of Wisconsin, as you can see on the map here, serving 10 counties with primary care services, dental and behavioral health, as well as substance use, and then partnering with other social service agencies as well. We are the only migrant health center contracted with the state of Wisconsin, and as such, are looking to provide services across 72 counties in the state of Wisconsin. You can see our mobile health unit here, the big rig in the picture at the base of the slide, is a 2-year-old state-of-the-art 40-foot truck that's been outfitted with 2 beautiful exam rooms and a central working space and phlebotomy station that we bring out to our mobile clinics. Next slide, please.
Wonderful. So some project overview. We will begin with the Wisconsin Farmworker Coalition. This group was steered by Family Health Clinica, and early on in the pandemic, when it began, this coalition began to see the rapid change of information with COVID. So with a multi-sector organizations, including nonprofits, healthcare, state and county health departments began to meet weekly just to be able to disseminate the information from when the guidelines came out to be able to provide the information to workers. A really cool thing about this specific coalition was that it also included employers of the workers. So we got to hear their side of guidelines and restrictions and how it was difficult on their side and be able to bring that up in advocacy to the state as well. An additional background information is that through this coalition and as well as advocacy, we were able to collaborate with the state of Wisconsin and have assistance with the National Guard to be able to do large group testing. At the beginning, it began primarily with PCR and later with supplies for antigen testing. And then just a huge thank you to La Clinica for being able to utilize not only just outreach staff, but also in-clinic staff to rapidly deploy the project. Next slide.
All right, the information here really is a review of last summer's work that we did. the key piece that we've all experienced was that information around COVID was changing so quickly. Literally felt like hour by hour at some points during the past year. So as we both planned our project for last summer and tried to scale up our staffing in order to be able to complete the work we were envisioning, one of the first things that we started doing with employers was worksite assessments. So for all the issues that Dr. Sinnwell had mentioned in terms of barriers or difficulties to really creating the best COVID mitigation strategies, we worked with employers to try and ensure social distancing as possible. Of course, sometimes the work itself does not allow that, and sometimes the congregate housing has really placed difficulties in those COVID strategies themselves. So although we didn't complete a lot of worksite assessments at the beginning of the season as we were just getting our project up and running, that did continue to be an important part of our ongoing education, both with employers and employees throughout the summer. We're proud of the amount of work that we did in terms of getting our team and bilingual educators out into the field. So working again across the state of Wisconsin to provide up-to-date education around the risks that were present for workers themselves, and presenting that information both at work sites, but also in areas where the employees were working and living, bringing information really to them where they lived. The ability to have both antigen and PCR testing allowed us to effectively collect information in real time, both with the rapid antigen testing for asymptomatic arriving workers, and then follow-up PCR screen. It was interesting to hear the work in Iowa as we did more and more testing. This really became very labor intensive for the staff, and people were really working around the clock 7 days a week to follow up on this. Again, mid-season re-education just refers back to the same point that we were constantly inundated with new information to share. And so we were tracking spreadsheets as to who we had already met with, and then updating information as best we could throughout the summer. Outbreak testing and support, we were trying to be as responsive as possible to both the workers and employers as these issues came up, and attempted to send either one of our mobile teams out to do the testing, or to work with partners with other community health centers or public health in those areas around the state. And then as the season was ending, many of the international H-2A workers did require testing before they left in order to be able to board airlines and fly home. So as you can see, we were able to reach out to over 3,500 employees with education, and almost exact same number of people were tested throughout the summer. Our overall positivity rate was only 6%, which I think is pretty amazing. If you compare that with Wisconsin's rates during that same time, it was significantly less. So proud of that work there as well. Next slide.
With that, we wanted to share a little bit of our project successes. A huge key part of this was being able to reach over 3 1,000 workers. Normally, the state of Wisconsin has about 7,000, very similar to Iowa, come up, including H2A workers. Even with our primary care season in previous years, we would be hitting a little under the 400. So this was a huge increase on the population that we were able to see and the patients that we were able to help. Continuing with that, we were able to, since we had that open communication with employers and workers, keep up with the changing protocols nationwide and statewide for testing and asymptomatic workers, as well as just the health education. And probably one of the most important parts is that through our work with the migrant workers for such a long time, since we started in the 70s, we were able to really provide that culturally competent care in bilingual staff and just being able to meet where the workers were at. We did kind of a mixture of the health education, either in groups or more of like if people seem to have a lot more questions, we would our staff would take time to really hear them out. And if at that time there was like no answer, an example of it would be if people, like an example of that for now would be if people, how long would the vaccines last? Sometimes that still has no true answer. Just being able to kind of like reassure of what information is constant and what information is known. And then another partner success, project success, is the collaboration with the partners. As we mentioned, it was crucial for us as being the only migrant working health center to be able to collaborate with health departments, other community health centers, as well as like with the state to be able to reach all the migrant workers that we did, and being able to just provide any outbreak staff support, or just even being the bilingual interpreter in some of the cases as the patients maybe didn't get tested through us, but we were able to really help out in those sense. Next slide.
As part of our project review from last summer, we did some interviews with our own staff to understand more what their reaction was to the work. It was a really busy summer, and it was something that we wanted to make sure we got some lessons learned from. And this was one of the stories that a staff member shared with us. One of the local employers actually brings in H2A workers from South Africa. And it was actually a small outreach towards the end of the summer that we were completing. And it was one of the instances where we were doing testing in order for those particular employers to be able to prove to the airline that they had a negative test within 72 hours before travel. So as an example of that information that travels between various individuals, they had heard of someone else who didn't have the correct test, and so was actually not allowed to board the plane and had to pay a significant financial penalty to get a different flight, and did not return home on the day that they were so looking forward to seeing their family and loved ones after a long and busy season working here in Wisconsin. So that employee was able to review that our testing did meet the requirements of the particular airline that this person was going to be using, and that would save them concern about whether they would be able to return home on time and see those that they really were dying to see after their season here in Wisconsin. So that personal touch and outreach was something that I think was really sustaining in terms of the work for that particular individual. Next slide.
Yeah, and we wanted to add an additional story, understanding that with COVID, everybody seemed to be COVID. This specific story came from our primary care outreach and services. We had a gentleman that, because of his worries with the pandemic, decided to get a general physical. The appointment did take a bit of a turn when he was diagnosed with HIV. He was worried. He was very, very almost in like despair, not knowing that we're in a pandemic. Our provider was able to really take time and talk to him and understand and really affirm that we would be able to assist in the coordination of care. From then on, they were taken to our health education station to be able to further discuss the diagnosis and what that was going to look like for this patient, and then continue on to transition him into another treatment facility so that he could get the full care right there and then. And this was really, really intense for this patient. And later on, when he called back to one of our health aides, he just was very, very grateful and understanding that if primary care was not available because of the pandemic, his life could have been very different still. So this is just a story to encourage, understand that sometimes it's harder to enhance those protocols, like using the PPE in the middle of really, really hot summers. But it's really crucial services that the patients, the migrant workers, sometimes are not able to get. So with that, next slide.
Hey, we did want to take a few minutes and think about some of the project challenges, things that we've been reviewing this over the winter and hoping to make some impact on as we move into this season as well. So we've talked about the novelty of this new virus and how knowledge was changing in such a quick manner. Certainly public perception, whether that's nationally or in the state of Wisconsin, even at upper levels of government in the state, we presently have a Democratic governor who is providing certain types of public health information and a Republican legislature that was at odds often with some of the pronouncements that were made from the governor's office. And so this challenged some of our educational efforts as well. Just the rates of community spread were an important factor throughout the summer. And all of us saw those numbers sort of increasing and decreasing over time, but anxiety often was associated with increased community spread as well. In terms of our outreach work, we've got some employers with hundreds of employees and some with a dozen or less. And no matter the size of the farm, some of those workers may be arriving in different waves. And so these were logistical challenges that we needed to overcome and really sort of size and scale our employee work groups to be able to go out and work with each of these employers that was calling from around the state and needed help with testing and mitigation strategies. We've talked already, I think, about the close working and living quarters and the importance of education there. And then also the quarantining and isolating. So some of the large employers really were better prepared with physical spaces for this. Actually, interestingly, one of the most difficult things was finding separate bathroom space for individual employees to be able to use. And then the smaller employees often really did not have the ability to physically isolate patients. And so we had to do the best we could in terms of those recommendations as well. Next slide, please. Funding issues. Last summer, we had a population health grant from the Medical College of Wisconsin as well as state funding. And going into this year, it looks like primarily we'll be looking at federal and state funding to help us. The rapid staffing increase really challenged our human resources department, but we found really that people wanted to contribute to a response to the pandemic. And so we had a lot of really great people working with us last summer. Contact tracing, of course, was often not as available to our demographic. And so this was where we really worked with our coalition and other partners to do the best we could. And some of that work then really came down to us working with employers and sometimes the employee's ability to help us understand how we could best test and follow up with patients. Doing a lot of outreach and education. HIPAA concerns and privacy were always things that we were working to maintain. And then there's really been some occupational safety laws which didn't necessarily protect workers specifically with the needs of the pandemic. And so it was very helpful to us that the state's workforce development office was one of the active partners that we had. Next slide, please.
Yes. So looking ahead from last season, we are currently evaluating and revamping kind of our processes to continue on our services, including the site assessments, the testing, and now the vaccine that's on the bottom. We are searching for that replacement of our MCW grant, and specifically that one has more to do with health education, but currently we are state funded, which was a really good, leaves us in a really good place. Additionally, we are thinking on expanding our season, or we have expanded our season for primary care. In previous years, we only operated from June to end of August, September. And we, looking at the data, realized that H2 workers and the migrant seasonal agriculture workers in the state of Wisconsin are mostly here, starting early March, and then end pretty late in November or even December. So really hoping to expand that. And then, as mentioned before, we are vaccinating, which has been really a great partnership with the state because they've been able to help with the allocations of the vaccine. For planning purposes, we advocated a lot. When Moderna came out, we advocated for Moderna just because of the way of transportation. And then now that Janssen came out from the Johnson & Johnson vaccine, we also advocated for that. Because it is a single dose, and knowing that the population can be hard to track twice, that added a huge logistical component on our end. Next slide.
Right. Thank you, Netzali. I think, yeah, you covered really much of what we've focused on in terms of our ability to vaccinate as many workers as possible in a short amount of time. And so working with our state partners from the beginning to be able to get the vaccine that was going to have the least logistical problems. And now the ability to have a single dose vaccine has been really extremely helpful to us. We found that the employees as well as employers have been happy with this development, and that we're able to come and take care of this in a single outreach mission. And so at this point, the state has told us that we are really being prioritized because of our outreach work for the Janssen vaccine. Next slide.
Yeah, and we wanted to also share just a little bit about what that looked like for us. We are actively preparing for mass clinics. Last week, we did a mass clinic. Our first mass clinic was about 210 workers. We were able to kind of try it out a little bit last season with small scale flu shot clinics, which were really able to provide a lot of those logistical things. Like the refrigerators, the temperature sensitive vaccines. Considerations is that education really is key. Out of many things that we were preparing for as we were advocating for the Janssen vaccine, the last thing that we had prepared for was for a bishop to come out with their opinion on the vaccine. And that was something, as we look into our population, the Latinx community does lean Catholic. So just being able to hear and see and take information, and then later on hear from the Vatican that they did recommend any vaccine that was available. So just being able to provide that information to the workers and showing them that has helped with some hesitancy. And then another thing is we cannot mandate the employers to receive the vaccine. That definitely is a personal choice. So just trying to do the best part of health education, being able to answer anything that they have, and then just being able to provide the vaccine, hoping that the workers would receive it, just because of many of the previous things that we talked about, like the congregate setting and just tight quarters and working spaces. And then just acknowledging that currently, as people begin to come from Texas and Florida, primarily for us, there is no national tracking registry. So we are having to begin to see folks coming in with one shot, and then us trying to scramble around to see when they got it, what did they get, and if they still qualify for that boost or not. And that another point for that one, I will say, is just the addition of international vaccines. There's vaccines in Mexico that are approved there that we do not have in the United States. So just being able to be mindful of that with our health education if questions do come up. And then just continuing on strengthening those partnerships with community and public health departments, as well as our community health centers. Next slide. And we just want to say thank you to the Family Health Clinica team. We do have our information. I will leave just a few more seconds for anybody to screenshot it. Alrighty. And then that does conclude our presentation. Thank you.
Great. Thank you, everybody. That was a great presentation, very detailed. It's exciting to see what's going on around the country. It's also interesting to hear what all those challenges are for everyone. Dr. Kinsey, there was one question in the chat. I'm going to encourage those that are still here waiting and listening, feel free to throw in questions in the chat and we will get through them. But there is one that came through. The question was, when providing education for workers and employers, did you have to get permission for employers?
Generally in these situations, we've had long-term relationships with employers. And so that backbone of a trusting relationship was really helpful when we came to all of the details of last summer's response to the pandemic. So we were working sort of hand in hand with employers and workers. However, we do want to make sure that we're not allowing employers to be the guiding source on these, and that we are providing the same opportunities for employees that have not had an employer checking with us. And so we continue to reach out from our organization, but also with those other state partners so that we can get information to everyone as equally as possible.
Great, thank you for that. We have a few more minutes left. Any questions that folks have, please feel free to enter those into the chat. Now give it a second or two. There's a question, Iowa, how many mobile units do you have? And does your dental team go out with you?
I'll go ahead and take that one. So thanks for the question. We do not provide direct dental services. That is something that we do voucher out. We also provide care for the entire state of Iowa. So it's very interesting to hear your experience as well. We do not have a mobile unit like a van. That looked very nice, and hopefully one day we can get there. So we have 3 locations in Iowa, like clinics. And just to be clear, we only see migrant and seasonal farm workers. So we're specialized in that population. We don't see other groups of people yet. So we have 3 clinics in Iowa, standing clinics, Des Moines, if you're familiar, so central Iowa, eastern Iowa, and then northern Iowa. But we go out and we fill up vans with labs and pharmacy and tables, and we set up where the farm workers are. So we'll find places like cafeterias or laundry rooms. So hopefully that answers your question.
Great, thank you for that. And next question, again, Iowa, how many counties do you cover? Well, it sounds like you just answered in all of that. So we've got about 5 minutes. So just a few more minutes for questions. Anyone else? In the meantime, just a reminder, I have inserted the evaluation link into the chat box. Just a reminder to please complete that. It would be great for us to get feedback and learn what else we can do more and to better the conference as a whole. Another question, Iowa, what's the percentage of H2A workers that you serve?
I don't have the exact percentage. Dr. Corwin, do you remember the latest email and the number that were coming this summer?
So the numbers of H2A visa workers are, I think, increasing across the country because of other restrictions, other challenges, immigration challenges. So we're seeing more people come in with H2A visas. I think in the past we were running, for something over 7,000 workers across the year. We were running close to like 4,000 H2A visa workers, but we're going to see, I was just talking to Iowa Workforce Development, we're going to see probably closer to 5,500 visa workers this summer. And they come in, like Emily said, mostly from Texas and Mexico, and they are crop workers as well as CAFO workers, confined animal feeding operation workers. They work in the construction, for the seasonal CAFO workers, they do a lot of seasonal construction work.
Great, thank you for that, Dr. Corwin. Another question for all panelists. Do either programs or clinics have community health workers reaching the communities?
I could just speak for Proteus a bit. So a big part of our staffing, even our full year staffing, is training non-health workers to do health work. And so the core of part of our staffing is, young people primarily whom undergo training and learn to do ancillary health work. And always with the guidance of one of the more advanced practitioners. And then in the summer, we hire other additional health aides. And it's really remarkable how people come up to speed, learn and multitask and really step up to the plate. I mean, it really gives you insight as to why this community health aid model can work so well in other countries.
Great.
Yeah, to answer that from Family Health La Clinica, very similarly, we wrap up very early in the summer with many health aides to equip them to provide that information to the communities. We do not have a standalone health worker program, but it's in conjunction with our primary care services.
Great, great. So we are right at 4:59. I've got one last question I'm going to throw out there. What method of media communication are you using? Facebook, WhatsApp, Zoom, any other recommendations to communicate with workers?
We do have a Facebook page, but I would say our main communication with workers directly is WhatsApp.
Yeah, currently for La Clinica, we have a Facebook. We do have a website that people can reach us at. And we try to use our MyChart, which is our part of our EMR system that people can utilize the text message or even do through email. We are working on utilizing WhatsApp as more H2A workers do come up.
Wonderful. Thank you, everyone, so much. Amazing. Thank you to all our presenters. Thank you all for being here. Thank you again to Nonstop Wellness for being a sponsor. We will be wrapping it up now. Thank you so much, everyone, for being here.
Thank
Bye-bye.
you.
Thank you.